sugar, LFT, KFT, more hours than your urine routine. It is the parameter amongst all parameters. And without much ado, let's begin the talk, which are named ABC of CBC. So first, you can't begin a talk on CBC without addressing this gentleman. Anybody? Yeah. So he's Sir Wallace Coulter, who along with his brother Joseph Coulter gave us the Coulter principle, on which all modern analyzers, hematology analyzers are based. So without him, we won't be, taking this lecture out here today. So in most modern analyzers, there is a technology what we call as fluorescent flow cytometry. What happens here is that there is a laser beam throwing light at 633 nanometer. There is a forward scatter which shows cell volume. There is a side scatter that shows internal structure or the granularity of the cell. And there is a side fluorescence which is giving us the RNA and DNA information of the cell. So basically what it is telling us that the more immature the cell line, the more is the RNA and DNA content. So based on these three informations, we have something which we call as SFQ1, our analyzer. We can call it with VCS or some other name on some other analyzer. But what it is doing is basically these three information, it is tabulating into a cube. On the x-axis is the side scatter or the granularity. On the y-axis is the fluorescence or the RNA DNA content. And on the z-axis is the forward scatter or the cell size. So based on these three information, it is clustering different cell types into different cell lines. You look at this green dots here, these are basically nothing but your lymphocytes. You can see that they are on the extreme left of the side scatter, which means that they have the least granularity. And on the forward scatter, they are kind of placed a little bit in the mid segment with this pink cell line just ahead of it. So this pink cell line is the monocyte. So obviously monocytes are bigger than lymphocytes, hence ahead of the green area. But both of them have very little granularity. So on the left side of the side scatter. This area in the middle is the area of the neutrophil and basophil, which have kind of more granularity than the previous cell line. And this area on the right extreme is the eosinophil, which has the maximum granularity. This small tiny green dots above the monocytes, these small dots, these are the HFCs, or on some analyzers they are also called as the HFLCs, high fluorescence cells or high fluorescence lymphocytic cells. These are nothing but your old fashioned Downey cells, viral sites, transformed lymphocytes, call it as you may. These are primarily increased in most viral infections, also increased in certain lymphoid malignancies. This area above the neutrophil is the area of the immature granulocyte. This is nothing but your myelocyte, metamyelocyte and promyelocyte clubbed into one. They have a numerical value, they have a biological reference interval. So the higher the immature granulocytes, the more the shift to the left. This small area here at the below is the area of the nucleated RBCs. These are the band forms which are placed between the neutrophils and the immature granulocytes. This is the area of the platelet clump just next to the nucleated RBC, and this interesting area, which is called as the infected RBC, is the area between the neutrophil and the eosinophil. These are nothing but your malarial parasites. So now you can screen for malarial parasites in 100% of your CBC samples, even when the clinician has not asked for it, even when you are not looking for it. So with these, broadly we are going to discuss some novel new parameters that are available on the CBC analyzers, and I have broken it down into the three cell lines: RBC, WBC and platelets. In the RBC cell line, we are going to discuss automated nucleated RBCs, which now most modern analyzers can do. Reticulocyte count along with something called as immature reticulocyte fraction. This is a very interesting parameter, reticulocyte hemoglobin, especially in an iron deficient country like India. Optical RBC scatter plots and the malarial parasite or the infected RBC that I have just discussed. On the WBC cell line, we will be discussing the immature granulocytes, the neutrophil lymphocytes ratio, NEUT-Y. So this is nothing but the dispersion of the neutrophil along the y-axis or the axis of the fluorescence. So basically, more NEUT-Y means more RNA DNA content of the neutrophil and the high fluorescence cells. In the platelet, we will be discussing optical stroke fluorescent platelets and This parameter we all now know is immature platelet fraction. So coming to the RBC parameters. First, most modern analyzers can now calculate nucleated RBCs. We know that they are the very immature form of RBCs and are present in infants for a short time after birth. But in adult patients, they are basically showing stress erythropoiesis when bone marrow is trying to compensate for excessive loss of blood. So now these analyzers can not only calculate automated nucleated RBCs, they can also auto-correct your TLC. They will reduce them from your TLC and give you the correct TLC values. This is the case. You can see that the moment it shows this AND sign, the WBC has already been auto-corrected. We look at the nucleated RBCs, and even there is a flag. You can see that there is a flag of immature granulocytes and there is a flag of abnormal WBC scattergram, which means that the WBC scattergram is abnormal and something needs to be done about it. This is another scatter plot which is derived from our SF cube only. In this, on the y-axis is the forward scatter or the cell size, and on the x-axis is the fluorescence. This pink area here is the area of the nucleated RBCs. Right next to it, you can sometimes see a yellow area which is basophils, and this blue area is the neutrophils. This is called the WNB scatter plot. So this is a very interesting scatter plot. This can show these nucleated RBCs in stress erythropoiesis, can show basophilia, especially in cases of CML. And if this neutrophil is increased, obviously this is more in case of bacterial infections. Next, we have the reticulocytes. They are typically composed of only 1% of red blood cells and circulate for only 1 or 2 days. They do not have a cell nucleus but have a ribosomal RNA. So there are 4 stages of reticulocyte maturation. So as you can see from stage 1 to 4, the RNA content is decreasing. So this is the most immature form of reticulocyte. So this is the most mature form of reticulocyte. So stage 1 and 2 together are called as HFR or high fluorescence reticulocytes, since they are the most immature. Stage 3 is the MFR or the medium fluorescence reticulocytes, and stage 4 is the most mature reticulocyte or the least fluorescence reticulocyte. So this stage 1, 2 and 3 together are called as the immature reticulocyte fraction. So this is also important. In untreated megaloblastic anemia, reticulocyte count will be normal, but your immature reticulocyte fraction will be high. That is going to give it away. Next, we have something called as red hemoglobin. This is the most emerging parameter in anemia diagnosis. This tells us whether the reticulocyte is able to produce sufficient hemoglobin and appropriate utilization of body's iron stores. Red hemoglobin in combination with serum iron profile can be a very good tool to determine whether anemia is caused by low iron store in the body or inability of the reticulocyte to hemoglobinize itself. So what it does is, it diagnoses iron deficiency. It is the earliest measure of response to iron therapy, much before hemoglobin, much before ferritin. After administering IV iron to a patient, this parameter increases within 72 hours, so you know that you are on the right track. It is also an early indicator on iron-restricted erythropoiesis in patients receiving erythropoietin therapy, particularly CRF patients. So, this is recommended by European best practice guidelines for the management of anemia in patients with chronic renal failure. It has good correlation with serum transferrin, good correlation with bone marrow iron staining, and there is no other or manual method to detect red hemoglobin. It can be only done through an analyzer. I'll show you a case. Before that, this is the biological reference interval that we established in our own lab. Our normal range is from 27 to 36 picograms, but every lab will have to determine its own biological reference interval, as Dr. Dilip rightly said, because different analyzers have different algorithms, different fluorescence stains also. So this is a case of iron deficiency anemia before treatment. You can see hemoglobin was 9.4, MCV 69.5, REW 21.5, classical IDA. Red hemoglobin was 23.5, our normal range began from 27. Everything is pointing towards IDA. This patient got colloidal iron, and this is 3 days. Hemoglobin hasn't moved much up, 9.4 to 9.5. MCV is also there and thereabouts. Look at the red hemoglobin. From 23 it's jumped to 30.8. So it will be a dramatic shift in red hemoglobin within 72 hours of IV iron therapy. Next we come to something called as optical RBCs. These are nothing but RBC scatter plots in which we use, because in most stains which are using fluorescence, RBCs are isovolumetrically spherized. We use something called as the mild theory of light scatter for homogeneous spheres. The low angle scatter measures the volume and the high angle scatter measures the hemoglobin concentration or the MCHC. So we first spherize all the RBCs, and then this is the scatter plot. On the y-axis is the MCV with these two determinants at 60 and 120, and on the x-axis is the MCHC with two determinants at 28 and 41. It is obvious. This left area here is the area of hypochromia. This is hyperchromia. This is microcytosis. This is macrocytosis, and this middle square here is the area of the normocytic normochromic. Even without looking at any of the indices, just this scatter plot is going to give it away what it is in most cases. So this is the first case. Most of the scatter is in this area. There is some small tailing here, mostly normocytic normochromic. You look at the MCV, 91.8, hemoglobin is 15.4. This case here, this has got both microcytosis as well as hypochromia. This is classically microcytic hypochromic anemia, iron deficiency anemia. 9.4, MCV 69, RDW is 21.5. It is classical IDA. Look at this graph in contrast to the previous one. There is only microcytosis. There is no hypochromia. So, beta-than trait will always have only microcytosis. There will be no hypochromia. This is a case of beta-than trait. Just on the scatter plot, I have not seen the indices. Hemoglobin 12.5, you look at the Mainzer index, it's 10. RDW is normal, it is given away. The only problem will occur when there will be both ID and beta-than together. Then it will look like the previous graph of ID. This is case 4. You are seeing both microcytosis and a little bit of macrocytosis. It is basically dimorphic anemia, but more towards the lower side, predominantly microcytic. Look at the RBC histogram, bimodal peak. Hemoglobin is 9.4, MCV 71.8, RDW 38.4. So it is dimorphic but more microcytic. It was given away on the scatter plot even before I saw the indices. You can all now guess this is basically macrocytic anemia. Hemoglobin is 12.5, MCV is 101. So just by having a snapshot look at the optical RBC scatter plot, sometimes you are able to see a lot of things. They can assist in making clinical decision making faster. Sometimes unsuspected conditions can also be diagnosed. We have diagnosed hereditary spherocytosis just by looking at hyperchromia on the optical RBC scatter plot. So sometimes, it makes you diagnose more than all the blood indices put together. And there is need for greater awareness not only amongst the pathologist, but also the technologist on the bench, because he has to ultimately bring it to the notice of the pathologist. Next, I told you about the malarial flag. It is a reliable detection method for malaria incorporated into the CVS analysis. In a busy lab, it has the potential to identify even unsuspected cases of malaria. I'll just show you this. So, this is a case. I show you that scatter plot. This is the neutrophil area and this is the eosinophil area. But there is something abetting. When you rotate this plot, you can see that there is an area of this blue area that differentiates from this area. So this is the area of the infected RBC or the malaria flag site. The machine will also give you a flag for the infected RBC. That flag will also be there. So you can see that in this case, this is the flag for the infected RBC. So the machine is going to give you out a flag. You can see it on the scatter plot. You can confirm it using your smear examination or your card method, but it is very sensitive flag, especially for the Vivax. Not so much for the falciparum, but for Vivax its sensitivity is more than 95%. Next, coming to the WBC parameters. So immature granulocytes, these are nothing but promyelocyte, myelocyte and metamyelocyte put together. These are basically markers of bacterial infection and sepsis. The biological reference interval that we established at our lab was from 0 to 0.7%. So we did this paper at ISLH Melbourne. We used these markers to predict sepsis. So the objective of the study was to evaluate normal hematological markers like NEWT-Y, NLR, IMG, etc. to differentiate bacterial infections from sepsis, and also to assess whether they can be used to predict sepsis and its severity, or it can be used as a marker during treatment for prognosis, just like procalcitonin. So these are our findings. At values of 492 for NEWT-Y and at values of 10.66 for neutrophil lymphocyte ratio, it showed good correlation. So the diagnostic sensitivity for NEWT-Y was 100%, specificity was 93% at these cutoffs, and neutrophil lymphocyte ratio had a lower sensitivity, 86.7%, but 100% specificity. So NEWT-Y was the more sensitive marker, and neutrophil lymphocyte ratio was the more specific marker to differentiate bacteremia from septicemia. So this was our conclusions, that NEWT-Y and NLR are promising markers to differentiate bacterial infection from early sepsis. These markers can form a robust screening tool to diagnose early sepsis. However, when we tried to correlate their values with severity of sepsis or response to therapy, it did not correlate that well. So it is not a substitute for procalcitonin. But when a patient of bacterial infections come to your lab, and even if you don't have fluorescence technology, basic NLR is there in the most basic analyzer. If you see NLR more than 10, you should alert your clinician that this patient could be going into early sepsis. At least advise a procalcitonin. Next, we come to the high fluorescence cells or the high fluorescence lymphocytes. I already described that they are nothing but your large lymphocytes. So this I am showing, it has got great prognostic value in dengue patients. They usually tend to begin to increase from day 4 of the fever. First 3 days they are normal. The normal range established at our lab was 0 to 0.4%. This patient I am monitoring from day 4 till the patient recovers. On day 4 the platelet count was 91,000 and the HFC value was 0.6, borderline increased HFC values. You look at the scatter plot here, you can see these small tiny speck dots, green dots. These are the high fluorescence lymphocytes. Same patient day 5, the platelet count went down further 58,000. HFC has jumped from 0.6 to 7.7. It's a nearly 12-13% jump. So whenever there is a more than 4 times jump intraday in HFC values, usually the platelet count begins to increase within 48 to 72 hours. So an intraday jump of 4 times or beyond of HFC is a good prognostic marker for platelet recovery in dengue patients. Same patient day 6. Sorry, from the day 5 scatter plot, you can see there were few tiny dots here. Now there is this big tennis racket kind of appearance, classical appearance of HFC on the scatter plot. Day 6 platelet count further went down to 53, HFC further increased to 15.9, but nothing like the previous time where 13 times jump. This was just about a 2 times jump. Day 6, you can see the scatter plot is now more intense for the HFC. Day 7, further decrease 41, HFC is gone up to 19.9. On day 5, we had seen that jump. So probably next day it should definitely improve. It's already plateauing. This is the scatter plot. Day 8, the platelet has recovered. HFC has come down. So HFC going down will correlate with platelet recovery in all these cases of dengue. So this is the day 8 scatter plot. So to summarize what I just said, IPF begins to rise with peripheral platelet destruction in dengue patients. So does the HFC. HFC increases from day 4 of onset of fever. Platelet recovery begins within 40 to 72 hours of IPF values and an HFC jump of 4 times. A febrile patient in monsoon season with platelet count less than 50,000, IPF more than 20%, and HFC more than 5% total is almost certainly dengue irrespective of the serological status. I am saying irrespective of the serological status because NS1 antigen usually remains positive for the first 4 to 5 days. Even on the 5th day, sensitivity falls from 95% to about 65%. And the antibodies sometimes don't come by day 7 to day 8. So that period between day 5 to day 7 is the window where both your antigen and your antibodies could be negative. But this CBC is going to give it away for you. Next, coming to platelets. So this is a normal platelet histogram. You have two flexible discriminators at 2 to 6 and 12 to 30 femtoliters and one fixed discriminator at 12 femtoliters. So the graph should begin from the baseline and end at the baseline. This is the normal thrombocyte histogram. If I see a histogram like this, I am okay to report a 30,000 count also. I don't even need to see a smear. I will report it as it is. But if I am seeing these kind of platelet histograms, then I will be very wary to even report out a 1 lakh count also. I would want a smear validation at least, if I don't have a fluorescent plate. So various methods of platelet estimation we have done in our legal case for those of you who fought that case for dengue. The impedance method, the optical fluorescent method, switching algorithm where the machine chooses between which is better between impedance and fluorescent. So in most of cases of peripheral platelet destruction like dengue, ITP, etc., the optical stroke fluorescent method is better. But when you see patients of cancer chemotherapy coming to you, all those WBC fragments are going to be counted into the fluorescent platelets. There the impedance method is better. So these days machines are smart. Looking at other things, they are recommending which method is also better. Then we have immunoplatelets, which are nothing but CD61 tag platelets. They are as good as the reference method, which is flow cytometry. And last but not the least, the manual method that we've been doing for donkey's ears, chamber and smear validation. And believe you me, sometimes even the fluorescent platelet cheats me. I always go back to the manual method. It is the most time-tested method. So this is the optical platelet, this is the platelet histogram, this is the RBC histogram. So there is this overlap area. These large platelets and platelet clumps are sometimes counted into the RBC. And this is the main problem with the impedance platelet. Because if 50,000 platelets are counted into RBC, RBC का कुछ नहीं बिगड़ेगा. RBC तो already 40 लाख थे, 40 लाख 50,000 रिपोर्ट करते हैं. But if you count 50,000 less platelets, so say a difference between 80,000 and 30,000, it's a chalk and cheese situation. So there, that is why these impedance platelets don't work in dengue or any other cause of peripheral platelet destruction. You need to do a second method, which is either optical fluorescent or smear validation, whatever. So coming to this IPF thing, IPF is nothing but the number of platelets in the IPF region, this region here, upon the total number of platelets into 100. So if you look at, I'll show you this first and then we move to the, if you look at the IPF, this is forward scatter or the cell size, and this is the fluorescence on the x-axis. This green area here is the area of the IPF. So IPF is not just platelets which have high fluorescence, they are also giant platelets. So platelet people who are living in areas of macrothrombocytes like Harris platelet syndrome patients or Mediterranean platelet syndrome patients coming from Calcutta or Pakistan will also have high IPF because of the giant platelets, not so much because of the reticulated platelets. Coming back to the workflow that we follow. So we first run a count. If we see that the platelet histogram is normal and the platelet count is more than 50, we report as it is. If the platelet histogram is abnormal or the platelet count is less than 50, we run in the reticulocyte mode and then we do an optical or a fluorescent histogram and use a switching algorithm. This is the basic workflow of platelet that we follow in our laboratory. Immature I already discussed. Now coming to the ISLH guidelines. There are certain guidelines for smear reviews. When the platelet count is less than 1 lakh or more than 10 lakhs, whenever the machine gives any platelet flag, abnormal platelet distribution, giant platelets, platelet clumps, whatever, you have to recheck through the slides. Briefly, I will touch upon the 3 papers that we presented on dengue. So this is my first paper which I presented at AIIMS Research Competition in 2015. So what we were trying to do here was, we were trying to establish peak immature platelet fraction values in thrombocytopenic dengue patients and look for time to recovery from those peak values. So the basic hypothesis was, if majority patient shows platelet recovery within say 48-72 hours, it could be used as a predictive marker for clinical decision making. These are our results. The peak IPF values of patient range from 5.5 to 38.7% with mean of 13.5 and a standard deviation of 6.14. One thing was very clear. We cannot put any ballpark figures to IPF values. We have to follow it like a trend analysis. And interestingly, 6 out of the 7 patients whose peak IPF values were above 20 were ethnically from West Bengal, Bihar and Eastern UP. I understood that there is a genetic component to it, which was proven by a paper from Calcutta by Dr. Sen Gupta later, where their normal reference interval for IPF was 15-16 compared to our 5-6-7 that is coming from the northern part of India. So 100% of our patients showed significant platelet recovery within 72 hours, and hence it show a good correlation with time to recovery of platelet counts. So our conclusion were that peak IPF marker is a promising predictive marker. A single value of 10% is not reliable for platelet. I've used this word 10% because at this point in time there was only one study from Hinduja Hospital which said an IPF value more than 10% was a reliable marker for platelet recovery. So basically on that assumption only I've done this paper. So I busted that 10% theory, so that is why this 10% is coming here. And peak IPA values in dengue patients of different ethnic groups can be a subject for further study, which eventually proved out to be. So as they say, I was first time lucky, I got the first prize at this competition for this paper. So then we did another paper in 2016 where, we were comparing 2 different analyzers, Mindre and Sysmex, and see whether, IPA values trends change between these 2 systems. So this study I had jointly done with Medanta Hospital since I don't have the Sysmex system. So if you can see the Deming regression curves, the IPA overall R value was 0.960, for less than 6 was 0.972, for more than 6 was 0.901. Even optical platelet and mean platelet value showed good correlation. So broadly there was not much difference. The biological reference intervals could be different, but broadly the trend analysis across both analyzers was pretty similar. So we got a 3rd prize for this at API Global Healthcare Summit. And this is my final paper that sir was there with me in Vancouver when I presented this paper. Predictive marker in dengue journey so far. So what we did here was, there were a lot of other markers that were gaining traction for prognostic markers. We put all of them together. We put mean platelet volume, IPF, HIPF, high fluorescence cells, neutrophil lymphocyte ratio, platelet lymphocyte ratio, platelet HFC ratio, and we saw that which was the better parameter amongst all these parameters for platelet recovery. So this was the delta value for the parameter. You can see that the best response was coming for platelet HFC ratio, which was actually, if you look at statistically, is true. While the platelet count is falling, the HFC count is increasing. When you use it as a ratio, it will augment even further, because the numerator is consistently decreasing and your denominator is consistently increasing, so the values is going to reach a nadir point pretty fast. So this was a fall and jump. So we had, apart from the individual parameter, we had also done fall and jump. So again, the same PHR fall was coming to be the best prognostic marker. So this, we could establish the utility of both PHR trough and PHR fall as the best predictive markers of platelet recovery amongst all these parameters put together. So with these words, I'd like to thank you all. If there are any questions, I'll be glad to answer.